house. I don't know what that is, but yeah, it's a good brand. You made dad like the trial run, what kind of like. No, I just put coffee in there. It's a big jug, but it's worth it. It's thick too. Okay, guys, where did we leave off? What slide? 80. 80. I did too, but then I was fooling around in here. Okay. How's everybody doing? You guys all right? Is it hot in here again? It's a little warm. You guys gave me a heart attack last night. In the middle of the night, I woke up, I couldn't sleep, and so I got on my phone and I looked at Canvas and I'm like, there weren't. Some of you were up really late. But when I got up this morning, 36 submissions. So I went, okay. Some of you were up really late last night. Okay. Did you guys have more time to kind of absorb when the assignments are due, what's going on, all that stuff? Okay. Let me know if you have issues. Some of you sent me messages about the extra credit, and we'll figure it all out, okay? I think if you talked to me the other day, I have accommodation letters. If somebody else didn't talk to me, come and see me, okay? So everybody who talked to me, I think we're all set, okay? We're gonna finish up post-op today, and then we're gonna move into, what are we moving into? GI assessment and nutrition assessment. We're gonna kind of zoom through that a little bit because GI assessment, you guys already have, right? We've had GI, it's like a refresher, but I think you need it in here because it's just, we're doing a lot of it. So we'll buzz kind of through that. You guys know that our next class, which is when? Monday. Because Monday isn't Labor Day, it's the next Monday, right? Yeah. So Monday we have a quiz, right? Yes. Yeah. On paper, in class, I start at 9, okay? You need a green Scantron, okay? Green Scantron. You can get a red one too, just don't get those funky ones. You know what I'm talking about? Those crazy funky ones, they don't scan. So if you can get a green one, that'd be great. But a skinny red one works. So just make sure you got a Scantron on Monday. Yes?
For the exam, what chapters are going to be on?
Exam, it'll be everything we cover up till then, which should go through oral, esophageal, and stomach.
Okay.
Okay?
Thank
So everything we lecture on from now, you know, the beginning until Thursday. Yeah, next Thursday, right? Mm-hmm. Yeah. There we go. I'm kind of a little mixed up this week, what day it is. So stay with me or bear with me, I should say. Okay, so Periop, just a little refresher. We're talking about Periop, very generically, not a specific surgery, very generically as a whole, okay? So that's where your critical thinking comes in when you take your quizzes and exams, right? I'm not gonna ask some generic question, I'm gonna be more specific. And you have to really put on your thinking cap and apply what we've learned to that person at that time, right? So I'll ask you a question. This patient is having XYZ done, and you're the pre-op nurse. What statement made would cause concern and immediate reporting, something like that, right? So then you have to read all your statements and really apply what we've talked about to that person in that situation. All your questions are critical thinking. None of them are memorization, and you know, you have to really think like a nurse. So why do we do that? Why do we make questions like that?
So you get your thinking caps like a nurse.
Right, so you get your thinking cap on, right? Yeah. We want to make sure you guys can critically think, communicate well, use technology safely, all these things, all these NCLEX criteria, okay? So the questions are multi-layered. That's why you're gonna look at these questions and maybe not have seen these type of questions before, okay? So I want you guys to be aware, you're gonna have to do some critical thinking. Okay, so we are on post-op now? Is that what we're doing?
Yeah.
Okay, so we got out of PACU the other day. We met our Eldreddy score, or our Eldred score, I think it's Eldreddy. But anyway, we're out of PACU and we're going to the floor, let's say, okay? So maybe you're gonna receive this patient on your floor after surgery, okay? So this is the kind of things we're talking about, assessing, recognizing, and taking care of, okay? So, now this is our PACU score sheet. So here, respiratory is first for a reason, right? Remember, we were talking very generalized about what type of anesthesias you'd receive. You guys need to be able to apply that general anesthesia has more complications than if we have a little local incision made, right? Okay, so respiratory complications are first and foremost if we have general anesthesia, okay, or any anesthesia where our airway was compromised during the procedure. So all these factors can come into play after a surgery with our respiratory system. What's atelectasis, guys?
The alveoli collapse.
The alveoli collapse. So why do they collapse?
Because of itching.
What's that?
Buildup of secretion.
Okay, could be buildup of secretions. What else?
Down too long.
Down, you're
They're-
down.
They're sedentary too long.
They're sedentary too long. Okay, that's great. What else? Improper lung expansion. That's awesome. So why would you have improper lung expansion?
Because the ventilator's breathing for them.
The ventilator's breathing for you, right? And then after you're off the ventilator, are you still kind of sedated?
Mhm.
Right, a little bit, your respiratory muscles aren't working maybe appropriately. Did we also have maybe neuromuscular blockers,
Mhm. Slow down everything.
right? Are we paralyzed then? Yeah, so if that isn't properly reversed, or if some of that medication floats around and gets back into our system, Mark?
So if they increase the PEEP on the vent, would it help with atelectasis?
Well, we're talking about off the vent.
Right, but
We're talking about this patient's off the vent and we're on the floor, right? So they might be breathing great when they get back to you, but an hour later, things can change. Okay, so really focusing in on respiratory, but yes, atelectasis happens because we're not and popping open our alveoli, so they collapse at the base of our lungs, right? So what else can cause that? Being old? Yeah, sure, okay. But specific, awesome, Sarah said it. Being in pain, right? What if you have an open heart surgery like our patients on CPCU get? We do a mid-sternal, cut your ribs open, do our surgery and sew you back up. Couple chest tubes, pacemaker wires sticking out. You're hurting, right? So imagine a big incision right here. Put your hands right here. Go like this, everybody, go like this. Okay, take a big deep breath. See how everything opens up and moves? Are you gonna wanna do that if your chest is sewn shut? No, or if your belly is cut open, right? So how do you breathe? Like that, right? So you don't pop open those alveoli. So what is your job as the nurse?
Teaching breathing, incentive spirometer.
Yes.
Educational.
Coughing and deep breathing if it's allowed, right? If we have a big hernia, who said that the other day about hernias? What's your name again? Dominica. Okay, I don't think I asked you your name the other day.
No, you did.
Because I would remember that one. So, yeah, I mean, if you have a big belly surgery or hernia surgery, we don't want them coughing, right? Because we'll push out those loops of bowel. But other surgeries, we want to teach them cough and deep breathe to open up those alveoli. Why? Why don't we want atelectasis? Can lead to pneumonia, right? And that one's up there too. We can get a PE after any surgery. right? What is a PE?
Pulmonary embolism.
Right. Can you die from a pulmonary embolism? Yes,
Yes.
very frequently people die. Okay, so it's really a big deal. So respiratory assessment and monitoring is critical, okay? So this would be a nursing diagnosis or really a collaborative problem, but potential for decreased gas exchange, right? If we have any of those issues going on, we're at risk for improper gas exchange, okay? So all these things, anesthesia, pain, opioids, immobility, okay? So what is our outcome? Remember we said we're gonna write a nursing diagnosis and then come up with an outcome. So if our problem is potential for decreased gas exchange, what are we gonna say our outcome will be?
Patient maintains adequate gas exchange.
Oh, I love that. Did you guys hear Haley? Patient maintains adequate gas exchange. When?
During my care.
During my care. Be specific, right? When you write those nursing diagnoses in clinical for your instructor, be specific, okay? And how are you gonna do that? What are your interventions then?
Early ambulation.
Early ambulation, great.
Incentives for all.
Yes, teach incentives to all the things we just said, splinting your incision so that you can cough and deep breathe. Were you practicing? Okay, you guys get where we're going. So this is how you study. This is how you think, like a nurse, okay? You think about what the problem is, what's the outcome, how do I get them there? Okay? All right, so we talked about a couple of these things. But when we're assessing respiratory, you guys should be looking at these things. Airway is a safety priority, right? So we have to look at, is the airway patent? Okay? Are we hearing patients struggling to breathe? Do they have stridor? Are they using accessory muscles? Okay? What is their neck alignment? Okay? Did they have a neck surgery? Do we have to keep their neck in a certain position? Right? Okay? And then all these things we're assessing as far as the quality of your breathing or, you know, the factors that you're looking at. We just said this accessory muscle use. Have you guys ever seen anybody using accessory muscles when they breathe? Yeah? Okay, you have, yes, no? This is why babies, when they go for their checkup, have to have their clothes off, right? Who's got kids? If you do, you know this, right? You gotta take the shirt off for the assessment, because we wanna see retractions in the chest, right? Same with your adult patient. Gotta lift up the gown. You can't see it through their gown, right? You can't hear lung sounds through clothing. You guys can't, right? Because you're learning. So get under the gown, okay? So always assess if your patient's receiving oxygen when you have them. And is this their baseline? Are they on oxygen at home? How much? Right? Maybe they're on 2 to 3 liters at home baseline. So that's not super scary if you see that when you come in. But if they're on room air at home and they're on 4 liters here, something's not right. Right? So we have to investigate. So pulse oximetry is very important. Okay, if you check your patient's pulse ox at rest and they're 99, does that mean they're A-okay? I don't know. Are they on room air? Are they on 4 liters? What are you gonna do when they have to go to the bathroom? What are you gonna do?
Bring an oxygen tank with them if they need it.
Yeah, I mean, put a pulse ox on them. Just because somebody's 99 at rest on room air doesn't mean that when you walk them to the bathroom, they're gonna stay that way. Do you need more oxygen when you ambulate or less? More, right? So this is why we do resting and exercise ambulation with our patients before they go home. Have you guys heard of that? Resting and exercise oxygenation study. So all that means is sit down, put the pulse ox on. This is what your SpO2 is at rest. Now get up and let's walk in the hallway with the pulse ox on. I want to see what's happening when you're exerting yourself. Maybe you drop down to 87%. Okay, we gotta find that out before these patients go home, right? Okay, so just keep that in mind. All right, so you guys see all these interventions, the things that we're looking for. In my clinical yesterday, we went into a patient room, and we said minimum for safety on our unit is always inspect your room and make sure you have an oxygen meter, a flow meter in the wall, right? Make sure you have suction set up in the wall. We're taking care of pretty sick people, so that's just a norm. Everybody gets suction, everybody has oxygen ready. Anybody ever set up suction? Yeah? Is it an easy thing to do the first time you do it? No, you don't know what you're looking at. There's multiple tubes, there's a big canister, there's all kinds of jazz, and you just go, oh my God. So can you imagine in an emergent situation, needing to suction somebody and it's not there? That's scary. So if you're getting a post-op client back, you need suction ready. So that's something you're delegating to your nursing assistant, right? I don't know, are you? If you are, you better know that that nursing assistant knows how to set up suction. Because ultimately, whatever you delegate, you're responsible for, right? Okay, just stuff to think about. We said all this, early ambulation, all the things. Okay, so lots of education then, from a respiratory standpoint, and we talked about these already, right? We start some of this education in pre-op. Do you guys remember that slide? We tell them ahead of time, you're gonna have to do all these things ahead of time, just to expose them and get them ready for them. All right, now we're talking about the cardiovascular system. We're kind of going through the body systems of what we're worried about post-op with our clients, okay? So many things can happen post-op, cardiovascular-wise, okay? And you guys can look at these, but anaphylaxis can happen for whatever reason. You can have a reaction to anesthesia or an antibiotic, okay? What is anaphylaxis? An acute allergic reaction. It can be deadly, it can be life-threatening, right? Your airway can close, right? Very scary. Anemia can happen after surgery from what? Blood loss, right? We'll send patients for an open heart surgery, their hemoglobin will be 12, and they'll come back out of the surgery and they're at 8 or 7s, right? And normally you kind of panic if somebody's in the 7s or 8s, right? But open heart patients, as long as they're stable, they're not short of breath, we don't transfuse them right away, because we just grafted blood vessels onto their heart and we don't want increased volume and pressure. Does that make sense? Yeah, but anemia is common. DIC, do you guys remember hearing about that? And A&P? Maybe put a little star by that. I might not throw 5 test questions, but you guys should know what that is, DIC. Okay, it's where you have a whole body clotting party. Okay, your body just starts clotting and throwing little teeny clots all over your whole body. Okay, definitely very high risk for dysrhythmia, cardiac dysrhythmias after a surgery. We see it all the time on our floor. Patients have a surgery and they go into AFib or have extra beats or what have you. Heart failure can happen as well, fluid overload. Maybe it's from the fluid we gave them. Maybe it's because they have a stiff heart, okay, or an ejection fraction of 15%. Usually people that have an ejection fraction of 15% don't get cleared for surgery. So we do cardiac clearance, right? Okay. All these things. Hypertension, hypotension, obviously. We monitor for that. Shock can happen. Hemorrhagic shock. Okay. Sepsis, very common. How do we monitor for sepsis? For fevers, what else? Okay, white blood cell count. Sputum, okay, yeah. But have you guys seen the sepsis criteria that you monitor?
Hypertension, tachycardia.
Say it, Mark.
Hypotension, tachycardia, fever, and a source.
Okay, all right, so we're monitoring for those sepsis criteria. A heart rate, tachycardia, actually, heart rate over 90 we look for. And 100 is a normal heart rate. It's what we teach you to memorize, right? 60 to 100. But in the hospital setting, if we start clipping up above 90, we want to catch it early. So we watch for high heart rate, WBC elevation, you look at lactic acid. Okay, I'm not gonna throw a lactic acid question at you, but you need to be aware when you go to clinical next week. Okay, look at those sepsis criteria on your patients. And then we talked about VTE, or preventing blood clots, that relates to the cardiovascular system. Okay, here's all your assessments. These are all the things you guys are supposed to be putting in your data collection boxes on your clinical log. Okay? So when you're doing your log and you're not sure, what goes in that box? It's your PowerPoint. That's what goes in the box, those things, right? Okay? So we've got our assessment, the things we're looking at, and then interventions. And we talked about most of those interventions already, right? I think so. Monitoring I&O after surgery is critical, guys. Do you do it? Are you monitoring I&O on all your patients? Just start now. Have you guys ever heard someone with an order for strict I&O? Okay, you're gonna hear this story again in med-surg too when I lecture, because it's a problem. Do you know why there's an order for strict I&O? Because when the doctor puts in an order for I&O, nobody does it. So then they go crying out Christmas, strict I&O, and they put another order in. You titrate medications, you titrate fluid orders based on how much fluid's going in and how much is coming out. We can't appropriately manage patients if we don't do I&O, okay? All right, and of course, don't forget to check your sites for bleeding, right? Okay, here's education and teaching. It's a lot of repetitive stuff here for you guys, right? So I don't think we have to go over everything in minutia. Neurologic system, neuromuscular, neurologic. Can we have a cerebral infarction or CVA or stroke after surgery?
Yes.
Absolutely. Absolutely. When you guys are in the clinical setting, the very, very, very first thing you should do every single day, go in, introduce yourself, and do a neuro check on your patient. Okay? You should. Why? Every patient, not just surgical patients. Why? Yeah, not just to make sure they're not having a stroke. Yes, you wanna do that, but you wanna establish a baseline. Are they alert and oriented? If they're not, why? Is that their baseline? Are they a confused person? Or did they get a sleeping pill? And now they're wackadoodle. My old lady terms, you guys will hear a lot of those, wackadoodle. My grandma used to say that. Neuro checks, super important, okay? Get a baseline assessment. But all these things can happen after surgery. Elderly people have old kidneys, okay? Sometimes they have chronic kidney disease, stage 3, stage 4. Can they process anesthesia like a young person? No. And sometimes they have a surgery and they're never the same. Has anyone seen that or experienced that, right? Yeah, they don't clear all the anesthesia like a normal person would, and it can affect them, especially if they already have some baseline cognitive issues. So keep an eye out for this stuff. Joint contractures, that can happen. If you have big long surgery and you're positioned a certain way, you can have an issue with your mobility after, okay? And then of course you can have nerve damage and paralysis after a surgery. It's a risk of a lot of surgeries, okay? Okay, so these are the things we're gonna do. Headache and vision changes, that's nothing to mess around with, guys. You know, if you have a post-op patient and they have a headache, unless they're me and have migraines, or, you know, something like that, chronic migraine person, any headache is not just, let me go get a Tylenol. It's a whole neuro check, and then further that conversation. You can get them a Tylenol, but if they tell you, I never get headaches, okay, listen to your patients. All right, you guys kind of see here some of our interventions. Any questions so far? No. Okay, education here. We always want to tell the patients what we're doing. Sometimes if we're doing neuro checks on our patient because maybe they've had like a little transient issue after surgery, maybe they had a little blip in their vision, and we furthered this concern to the doctor. We did a CAT scan and everything looks okay. but now we have to do neuro checks Q2. Okay, for 24 hours. You need to tell the patient, I am so sorry, but I'm gonna have to wake you up all night. Right? You do, you have to wake them up. If it's neuro's Q2, you wake them up, okay? So keep that in mind. We're gonna assess for all these things. The headache, vision changes, increasing back pain while talking. Okay, and then any sensory changes otherwise, right? Numbness, tingling, anything like that. Okay, now we're on to GI. So common to have nausea and vomiting after anesthesia, okay? So common, okay? But it's scary as a new nurse to have a patient that, you know, you walk in and they're just vomiting, right? Scary. So, not uncommon though, from the effects of anesthesia, to feel really nauseous. GI ulcers and bleeding are also complications of a big surgery, okay? Because we're under stress. Remember that stress response we talked about that goes into play, releases that cortisol and increases stomach acid, right? So it's very common to get ulcers when you're in the hospital for a prolonged period of time. So this is why we see all of our patients on like PPIs, right, acid reduction, and they'll tell you, I don't take that. You have to explain why they're getting it, okay? And constipation's a big one too, guys. Multifactorial reasons, but if we did a GI surgery, we've kind of gone in there and monkeyed around with things. Stunned the bowel, right? We've given all kinds of sedatives, pain medication, right? So your bowels are not gonna be right for a while. So we have to encourage that hydration, fluid, okay? Early ambulation. So here's our collaborative problem. Potential for decreased peristalsis, right? That means movement through the intestine due to surgical manipulation, opioid use, and fluid and electrolyte imbalance. It's a pretty good one, right? You guys can throw one of these out there on your clinical log, right? Probably have somebody like this. Did you guys have patients this week? Not? Okay. Yes, not much. Okay, you will next week, for sure. So what's our outcome gonna be here? So it should be directly related back to the problem, right? Measurable and time limited. So what are we gonna say?
Patient will make a full stool by the end of my shift.
Okay, Dominica said, patient will make a full stool by the end of my shift. Is that directly related back to the outcome? Yeah, kind of, right? Is it measurable? Yeah, it's measurable, because if they don't go, the outcome didn't happen, right? And then it's time limited at the end of my shift. But is it reasonable? Probably not. Maybe not, right? I don't know. I mean, maybe. Depends how aggressive we get with our interventions that come after this, right? But you guys see where I'm going, right? So maybe you could say something, you know, patient will have improved peristalsis on my shift as evidenced by positive bowel sounds and passage of gas or flatus, or, okay? That's a big one, guys. You have to assess for bowel sounds and passing gas. Okay, then we know we've got movement again. Okay, so here you go. Those are all the assessments. Some of these patients, depends on their surgery again, right? Not everybody with surgery is gonna have an NG tube, nasogastric tube, okay? But if they do, you're responsible for it. Make sure you peek in the book and look at how do I manage an NG tube, okay? I will probably bring an NG tube on Monday, so you guys can see it and play around with it and feel how firm and hard it is, and try to imagine what it would be like to have it shoved through your nose, down your throat. It's not fun. Okay, so we want to secure that tube. Here's some tips on it. Make sure you know what the order says. Is it low intermittent suction? Can we disconnect it if the patient needs to walk to the bathroom? Right, you want to know what your orders are. All right. Again, accurate I&O. Diet advancements in these patients after surgeries as tolerated. Okay, and this is so generic, it's hard to get real specific with you guys on how to advance a diet. It just depends on the surgery, okay? So we'll get more in detail when we study specific GI conditions, okay, and bowel stuff and all that. Okay, so now again, we're doing education on GI, and we've talked about all these already, right? Okay. Now we're in skin. Okay, what's gonna happen with our skin? Well, these are pretty obvious. Infection can happen. Does it happen in immediate post-op? No, not right away, right? Okay. What is wound dehiscence? Did somebody talk about a dehiscence in here the other day? Domenica, did you? What happened?
Well, her leg, she had a surgery to replace her right here, and she went to the bathroom, she slipped and it dehisced. And
So what
she
is
was-
dehisc? Tell everybody, not everyone knows.
It's when the wound opens up and just rips the skin open, so from the stitches.
Yeah.
Yeah.
So staple stitches, any wound that's closed, you should be assessing that it's well approximated,
There's a deep one too.
right? Well approximated, meaning the edges are together, approximated with each other, right? You're looking for redness, warmth, swelling, drainage, pain, all that stuff, right? But if it dehisces, it means it comes apart. What's evisceration?
When it comes out.
When organs pop out of a wound. You guys wanna hear a good story? No, I'm serious, this is the best one. It's the best one. I was you guys, this rotation, med-surg 1. It was like week 3. And I got a patient who had, some kind of, I don't even remember what her abdominal surgery was, but she had a big, no, it was transverse, it was this way. Her incision was straight across. She was overweight lady, obese lady with a big incision. And I was taking care of her, I'm collecting like my clinical log data at the bedside, right? And the surgeon comes in to look at her incision. And he turns around and he looks at me and he says, do me a favor, go get me a bunch of towels and come back right away. And I was like, oh, all right, like you're a nursing student, you do what you're told, right? So I went to the closet, I got like 3 towels, he looked at me, he goes, more towels. Okay, I went back and I got like every towel that there was. He had a staple remover. He started popping out her staples and her whole belly just popped open. Bowel started coming. He goes, make some of those towels wet. I almost had a heart attack, right? But I'm like, wow, so cool. Okay, so got some wet towels and he started mopping up all the fluid that was coming out, put the wet towels over the top. Yeah, I'm standing in the room and then we hear this. And it was my clinical instructor. She sticks her head in the door, she goes, time for lunch. Right? And he goes, she's not going anywhere. He goes, you're a student? And I said, yeah, I'm a student. And he goes, she's a keeper. He goes, because she's still standing. I was like, ooh. I like wounds though. I knew that early. But that was a serious dehiscence first and then evisceration. So that lady went to surgery.
So what was the reason that he removed the stop? It's like,
Because she had an infection.
Oh, yeah.
He said he thought he was gonna open it to heal from the inside out and put a wound back on her. He was gonna like let it heal for a couple days and then put a wound back, because it wasn't healing well. But then she dehisced, so she went back to surgery. Okay, so, yeah, and she didn't make a sound. She just, the whole time, didn't seem to feel anything, didn't seem to care.
I wonder how she didn't feel that.
Well, I don't know. She was a bigger lady, she had a lot of sub-Q tissue, maybe, she had diabetes. Okay, but that's evisceration, okay? Why pressure injuries with skin in the post-op period?
Because you're sitting a long time.
Yeah, you can get a pressure injury in surgery. So check your patient's bony prominences, everything, okay? You can get one after because you have reduced mobility. It depends what part we're operating on and what you can move and not move, right? Okay, always look back here, guys. Okay, always. If there's a dressing on already, like a Mepilex, do you guys know what those are? Mepilex, they're like to prevent pressure injuries, kind of like a soft, big pad for the coccyx. They're pretty big. Ryan, you've seen them? Yeah, so people see those and they're like, oh, there's already a Mepilex. Peel it back, look at what's under there, put it back. You need to assess, okay? So, obviously, we report dehiscence immediately, right? Evisceration is this here where bowel's popping out, or something is popping out, okay? Surgical emergency. So can you get some saline blue pads and lay them over the area and call for help? You should call for help first, right? Right? Okay, you can do that. A moist environment, keep the patient calm, right? Wanna lay the patient down, right? Do we want them sitting up?
No.
Why?
Sitting up and down.
Right, yeah, you guys get where I'm going, okay. So here's all the things we do. You could have drains after a surgery, right? Lots of different kinds of drains, so take a peek in the book at your drains. All these things. Know the difference in these drainage types, guys. You need to know that, okay? You need to know that. What these words mean, because you see them all the time. And these will indicate whether things are bad or not as bad. So you need to know what the words mean. Right, we talked about post-surgical dressing. Don't change the first one. Don't remove it, right? But if the patient's bleeding, what do? Apply pressure, get a reinforcement dressing, call for help, call the surgeon, whoever did this procedure, or rapid response, whatever your hospital protocol is, right? Okay. Sometimes we have abdominal binder if it's an abdominal surgery, right, to hold things in place. So that might be a Velcro kind of wrap that goes around the belly. Okay, if there's an order for one, you better have it on there. You do take it off though to assess. Here's some drains, okay? Penrose drain on the left, very simple. It's just a tube. We shove one end into the wound and the other one comes out on the surface of your skin, right? So, can bacteria get in there? Yeah, for sure. That's a T-tube drain. So, you know, if you've got a bigger area that we need to drain, then the T-tube, this part goes in, and then this part comes out, okay? So you're monitoring your drainage for the type, color, consistency, amount, all that. We've got over here a Jackson Pratt drain on the left, okay? So basically it's like a closed suction system, okay? So basically with the Jackson Pratt, this bulb collector attaches here, okay? And this is like a little tube, if you will, with holes. Can you see the holes? That's the part that goes in your body. And so it collects the fluid, it comes out the tube, and it goes into the bulb. But what you do with the bulb is, can you guys see this little piece here? There's a cap. You take the cap off, squeeze out the drainage, measure it, put the cap, then you squeeze the bulb to collapse it, put the cap back on. And you created suction now in the bulb, so it'll like pull fluid with the suction. Okay, this one over here is a hemovac, same concept, just not a bulb. It's for like more copiously draining wounds, but this is like an accordion. Anybody ever deal with one? Yeah. So Ryan, where do you work?
Select specialty.
Okay, so you've had clients with us before. Yeah, it's the same concept. You can empty it and you squeeze it down and compress it to create the suction in there. Okay. So you gotta not only monitor the drainage, monitor the amount, but you have to make sure it doesn't get yanked out too, right? Okay. So you have to explain and teach about those tubes and drains. Again, splinting, watch for infection, all this stuff. Proper wound care, hand hygiene, and then really, really good diet to promote healing. Okay? Protein, vitamins, proper calories. Okay? All right, renal urinary complications. We talked about how important the kidneys are for everyone in any situation, but we want to watch for acute kidney injury after a surgery. Okay, so maybe your kidneys were completely normal, but we've given you medications and antibiotics and all these things that are processed through your kidneys. Can you get an acute kidney injury if you're in the hospital? You sure can. So that's your job to watch those lab values, right? Your CBC in the morning to see if we're anemic, where our hemoglobin's low, we have a white count that's elevating, and then our BMP or CMP, basic metabolic panel, comprehensive metabolic panel, okay, to look at those electrolytes, to look for imbalances, look at our kidney function. How do we monitor kidney function? What do we look at? BUN, creatinine, and one more. GFR. Look at all three. Draw a little kidney on your data collection sheet and put those three things in there right now. Do it, okay? Then when you get to me in MedSurg 2, you'll be on top of it, because we're all renal, urinary, and cardiac in MedSurg 2. Let's start now, because I hear in MedSurg 2, nobody told us to look at labs. Come on, guys. All right? So we watch for all these things. Very common to get kidney stones after surgery and after childbirth, by the way. But monitor for kidney stones and UTIs. But sometimes we get catheters for these procedures, right? Okay. Oh, what do we think here? Where am I going with this one? What collaborative problem am I trying to depict here? Falls, safety, right? So many things factor into safety after surgery, right? Decreased mobility, cognitive issues from medications, right? Just being in a different environment, a scary environment, the stress, having to urinate, right? Getting to a bathroom that's different than the one at our house. All these things factor in. So what could our collaborative problem be?
Patient will have no falls on the shift.
So that'll be our outcome. What's our problem? Risk for falls, right? Or risk for safety issues, right? Related to whatever your specific patient has had going on. And then yes, that's your outcome. Patient will not fall on my shift, and then what are your interventions gonna be? Right, non-skid slippers, ambulate with assist only, bed alarm activated for safe, right? You guys see where I'm going. Okay. All right, kidney urinary, if we have a Foley, you're responsible for monitoring that Foley. Most facilities now, I want everybody to check next week. Where are we at? We're at Oral Health, Troy. Who's at Troy? Yeah? Okay. I know Jayden's at Troy. I saw him. Who's at, where else are you guys? Ascension, Oakland? St. John? Maine? Ross, that's Maine. And Royal Oak? Okay. So the Cornwall, Royal Oak, Troy, Beaumont, those will be similar, but I want you guys to, where was I going with this?
The catheter,
Where's the
like what the hospital policy is, like
You want us to check for,
Oh no, I know what it was, thank you, good lord, I gotta drink this, I'm sorry, I didn't drink my coffee this morning. I want to know, and I just lost it again, am I having a stroke? Someone do a neuro check, right away, I need a neuro check. It wasn't their protocol, oh, it's the care, Foley care. I wanna know what your Foley care protocols are. Okay, we used to just be like, dependent drainage. Make sure they're to dependent drainage, don't throw the bag up on the bed. That was kind of Foley care back in the day. Now it's like, every shift, you're washing the catheter, there's Foley care kits, and you gotta wash the catheter, right? Why?
Infection.
I call a catheter, it's like a little bacteria highway. They're just climbing right up there into your bladder, right? So there's Foley care protocols now. Hospital-acquired UTIs, totally preventable, and they kill people, so many people. They create urosepsis and people die. So we have all these protocols in place now. Okay. Related to urinary renal, what is this?
Bladder
Bladder
scanner.
scanner.
Bladder scanner. Okay, bladder scanner. Yep, you might have to use one of these. If patients are retaining urine multiple times, and we have to straight cath them to get the urine out, we may have to put a Foley catheter in. But it's very strict protocols. We don't do it lightheartedly anymore, okay? So INO, super important, okay? We get these catheters out right away after surgery, right? Whenever anesthesia wears off, depending on what we have, okay? So we get them out right away, but that doesn't mean our bladder sensation is back, right? So it's something we really have to watch. Encourage that fluid intake. Here's our labs, right? And then antibiotics if needed. Here's our teaching, which we just talked about, so we don't need to talk about it. Pain management, of course, warrants nursing care and intervention. So pain related to incision and procedure and positioning and yada, 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 right? So what is our outcome?
Patients have a pain level of, for example, 5 out of 10 in intervention.
Okay, so how do we decide what pain level we're gonna have?
If I ask,
What do we ask them?
What's your pain level?
What's your what?
pain level,
What is your pain level, first of all, but in order to have an outcome, what's acceptable? Was that Kim? Thanks, Kim. What's your acceptable or tolerable pain score? What would you like to get down to, right? Depending on the surgery we're talking about, some people have chronic back pain. They're always at an 8, right? Maybe their tolerable score is a 7, okay? So that's different. We want to assess and treat anything 4 or above. Did you guys know that? Yeah, it's like a JACO thing. We have to do an intervention. So if your patient says my pain is a 4, but I don't want any meds. They say that all the time, right? I don't want any meds. Then you say, would you like an ice pack? Would you like me to reposition you? Do you want to get up in the chair? Would you like to go for a walk? You offer something else, and then you document what you did. You do an intervention, even if it's refused. Then you put it in the comment, patient refused intervention, right? Okay, so outcome is patient will have a tolerable pain score of by 2 p.m., right? Make sure you're assessing your pain with your vital signs. It is a vital sign, guys. Assess it, get a tolerable score, get some specifics. Do you always have this pain? Is this new? Have you never had this pain? What's going on, right? And then, when are you gonna reassess?
after we have done intervention, so.
Right, you're gonna give an intervention and reassess within an hour, right? Okay, awesome, there you go. All kinds of stuff. For pain management, your patients might have patient-controlled analgesia, right, pumps. You have to do excellent education with your patients on how to use those, and with the family, okay? These things work great if no one gets near them but the patient, right? Somebody has surgery, they most times have a family member with them, right? And you know, grandma had her hip replaced and she's laying there and she turns, oh, ooh. And the daughter grabs the pain button and pushes it, right? Does that sound reasonable? I mean, it sounds reasonable if you're not medically trained, doesn't it? Grandma's hurting, I'm gonna push the button for her, even though she's half asleep, because she made a face, right? But this is how people die, they stop breathing. You're not gonna overdose yourself with a pain pump, because if you fall asleep, or your respirations go down, you can't push the button anymore, right? So we have to teach families that, really specifically. So always monitoring vital signs, like I said, we're looking at respiratory rate, level of consciousness, all those things. Plan activities around giving your pain medicine, okay? Somebody just had a big open heart surgery and they're getting up for a walk for the first time. I mean, you might wanna give them their pain medicine an hour before that, right, to get it cooking. Or else you're gonna have a non-compliant patient every time he has to get it, I'm not doing that again, right? Okay. Can also teach non-pharmacological pain management. Okay, some patients just don't know that there's other things out there that can help them. Okay, this is numeric scale on top versus a faces scale. So we would use that if someone, you know, is young, has cognitive issues, what have you. Here's our epidural oh, we need a break, don't we? Yeah?
Yes.
Okay. Take a quick break.